topic that I'm going to be speaking is on abdominal wall blocks, specifically pertaining to the superficial blocks. This is where I work in the United Kingdom, in a place called Frimley Park Hospital. I work along with Yuri. As you all know, the gold standard for most abdominal surgeries is still epidural analgesia. This is a large systematic review which put together all the studies that compared epidural versus no analgesia and or systemic analgesia, and identified that epidural conveys reduced mortality, lower risk of atrial fibrillation, lower risk of deep venous thrombosis, respiratory complications, and also bowel complications. But epidural has got a lot of side effects, which has been acknowledged in their systematic review: risk of arterial hypotension, urinary catheterization, motor blockade, which reduces their mobilization, and also it is very labor intensive. They have high technical failure rates, and it requires constant adjustments of the epidural technique. And as you can see from this review, that almost all the studies in all areas, they favor the use of an epidural. But these studies were all done pre-ERAS. And as I had alluded before, epidural requires a lot of manpower. There's a high failure rate. And in some cases, there could be catastrophic complications like vertebral canal hematoma or meningitis and infection spreading. Commonly, lower limb weakness is present, especially if the epidural is sited lower down. These patients, because of hypotension, end up with a lot of fluid and end up in requiring vasopressors, for which they'll need to be monitored in higher dependency areas. And many of them end up having a urinary catheter for monitoring their urine output. With the enhanced recovery programs, the goal is to mobilize the patient as early as possible, to use less systemic analgesic drugs and use a lot of regional anesthesia, and also in the regional anesthesia to be as distal and away from the spine as possible. So the more we stick to these principles, the early it is to mobilize these patients, and you'll be providing the patient with comparable analgesia to central neuraxial techniques. Whether they offer the mortality benefits and the risk of other complications, only time will tell us. But at this point in time, this is the theme. The other myofascial and trunk blocks have got a lot more advantages in that you could use it for emergency situations where the patient is coagulopathic or septic, or where the patient hasn't offered a consent to a neuraxial or a spinal technique. And moreover, the complications with these superficial techniques are very rare. They are very easy to learn. They give very little motor weakness, and the side effects like needing catheter, hypotension, fluid boluses is all very minimal. And these can be managed in a low intensity environment. In terms of manpower, these are ideal to get these managed in a ward setting. This is a typical anatomical section to show the abdominal wall nerves. The abdominal wall is innervated between T7 to L1. Almost all the nerves travel in between in the tap plane. So once the nerves emerge out from the spinal, once they emerge out as the spinal nerves, they travel in the tap plane. 1 second, technical failure. Yeah, they travel in the tap plane in between the internal and the transversus abdominis, and then they enter into the rectus sheath plane to become anterior cutaneous nerves. Midway in the anterior axillary line, they provide the lateral cutaneous nerve as well. So these are the nerves that need to be targeted between T7 to L1 for any kind of abdominal surgery. So the abdominal wall blocks that we'll commonly talk about are divided based on where they block the nerves. So if the nerves are blocked anteriorly, then it is a rectus sheath block. You block only the anterior cutaneous nerves. If you block them lower down in the transverse abdominis plane, it's either a tap block or a ilioinguinal block. If you block these nerves as they emerge out close to the paravertebral space, near the origin of the quadratus lumborum, it's called the quadratus lumborum block. And if you block these nerves at the exit of the spinal canal or the intervertebral foramens, then you have the erector spinae block. So these are the choices of blocks, superficial blocks, that could be used to provide abdominal wall analgesia. We'll go through some practical aspects of how to do these blocks and what are the considerations that you need to have when doing these blocks. The first we'll talk about is the rectus sheath block. This is the rectus sheath muscles. The rectus muscles are paired abdominal muscles that extend from the xiphisternum to the pubic symphysis. There are two muscles on either side. And if you see the posterior rectus sheath is where all the abdominal wall nerves travel, then they penetrate the rectus muscle and they come out anteriorly. So this is an ideal location to do the block where they are in a complete fascial plane in the posterior rectus sheath. So if you do a cross section at this level, you're going to see the paired abdominal muscles, which is the rectus muscles. Then you have the external oblique, the internal oblique, and the transversus abdominis. They form an aponeurotic layer, which becomes the linea semilunaris, and then they encase the rectus muscle as anterior and posterior rectus sheath. How does it look on ultrasound? If you place an ultrasound probe at the lateral border of the rectus, you'll see these three muscles, which is the external oblique, the internal oblique, the transversus abdominis, and the internal oblique splitting as the anterior layer and the posterior layer to form the anterior rectus sheath and the posterior rectus sheath. Commonly, the anterior rectus sheath is not blocked because of the digital intersections, which prevent the local from spreading up and down. So here you can see the external, internal transversus and the rectus muscle enclosed by the anterior and the posterior rectus sheath. And you get the transversalis fascia and the peritoneum behind it. If you move the probe a bit more medially, then you get purely the rectus muscle and the two layers which are seen as tram lines. The first layer is the posterior rectus sheath, and the next layer is the transversalis fascia, and this layer is the peritoneum. So, and here are the bowel contents. So that's the rectus muscle and posterior rectus sheath and the peritoneum. So the goal is to inject the local in between the posterior rectus sheath and the rectus muscle, which I will show you in a video. So scanning from lateral to medial. Scanning from lateral to medial, you have the external oblique, the internal oblique, the transversus abdominis, then the rectus muscle coming into view, the anterior rectus sheath, the posterior rectus sheath, the tram lines, the peritoneum and the bowel, the two tram lines with the transversalis fascia, then cross over to the midline. This is the linea alba, and the opposite rectus muscle will be seen over here. The points to be aware are, it's a somatic block. It does not give any visceral cover. It can block between T6 to T12. It does not cover the L1 dermatome. It gives a level of analgesia similar in the midline. It does not cover the lateral abdominal wall. It does not provide analgesia for stoma, drains, and transverse incisions, which extend beyond the midline. And as I said, the L1 dermatome, so any patient will have pain specifically in the lower abdominal area. That's because the L1 dermatome doesn't travel within the rectus sheath, and you need to do bilateral blocks for these surgeries. So the technique to do it is with a patient in the supine position. I tend to teach from doing a lateral to medial approach using a linear probe and a 50 millimeter needle and an 18 gauge 2E catheter. So the injection is behind the rectus muscle and above the sheath, the posterior rectus sheath. This is the posterior rectus sheath. You should be above the posterior rectus sheath, and you should produce a lentiform spread of local anesthetic. A volume of 20 ml of local anesthetic on each side would be enough to provide a sensory analgesia. And I use a lateral to medial injection technique. A cephalocardite technique can be used as well. a very flat trajectory would give you a good entry into the rectus sheath easily. Any steep angle, you risk entering into the peritoneum. So this is a typical demonstration of how to do a rectus sheath block. The needle entering from lateral, and then you're lifting off the muscle from the posterior rectus sheath. And in this video, you could see the rectus muscle being lifted off the posterior rectus sheath, and you could see a catheter being inserted behind the rectus muscle. And 2 catheters need to be inserted, one on either side. And they can be either having a manual bolus or an infusion. And you could see the peritoneum underneath. So level of insertion. The level of insertion can be anywhere between the xiphoid or the umbilicus. So below the umbilicus, the posterior rectus sheath is deficient and absent at a distance 1/3 below the umbilicus. So it's ideal to site the rectus sheath block between the xiphisternum and the umbilicus. The volume, as I discussed, is 20 ml of local on one side and 20 ml of local of 0.25% on the other side. The angle of insertion needs to be pretty shallow so that you enter the rectus sheath plane. Failure rate can happen, especially if the nerves don't travel in the posterior rectus sheath, or if the patient has had previous abdominal surgery where the rectus sheath is adherent to the posterior muscle. The second block that we'll talk about are the TAP blocks. These are the most studied blocks and well-tested blocks, and have got the best evidence at this point in time for recommendations. So the anatomy of the TAP blocks, as we discussed in the previous slide, T7 to TL1, they travel in the muscle plane between the internal oblique and the transversus abdominis. They travel in that muscle plane. So this is where we do the TAP block. So depending on what level you do, the TAP blocks have been given different descriptions. So if you do it just below the subcostal margin, it's a subcostal TAP block. Or if you do it just above the iliac crest, it's called a lateral TAP block. Or if you go even further posterior, it can be called a posterior TAP block. But in terms of spread patterns, so the block characteristics is pretty much the same if you do it at the level of the subcostal margin or the lateral TAP. So the injection is going to be between the internal oblique and the transversus abdominis muscle. So if you were to see, the lateral TAP block classically produces just analgesia below the umbilicus. So you can get a best spread up to T10. This is for the lateral TAP block, which is performed at the iliac crest. The initial studies by McDonald et al., where they used the 2-pop technique, could never be reproduced because actually they did a quadratus block rather than a TAP block blindly. So the ultrasound guided lateral TAP blocks only produce lower abdominal analgesia and are useful for either cesarean sections or hysterectomies. The subcostal TAP blocks produce upper abdominal analgesia, which is up to the level of T10. So from T6 to T10 is a reasonably good spread. So you could use it for upper abdominal surgery like epigastric hernia repair or for any upper open cholecystectomies. So the subcostal TAP block, as we discussed, are used for supraumbilical incisions such as cholecystectomy. And again, if it's a midline surgery, you need to do a bilateral block. So the probe is placed at the level of below the costal margin, and I use a medial to lateral approach, and it produces analgesia along this territory. So the lateral TAP, as we discussed, is for operations below the level of the, or at the level of umbilicus and below, for cesarean sections and hysterectomies, and they produce analgesia in this pattern. So with the patient supine, I use a linear probe and I use a 50 to 80 millimeter needle or an 18 gauge 2He if I use a catheter. And I use an anteroposterior technique for the lateral TAP and a medial to lateral technique for the subcostal TAP. I put in around 20 mils of 0.25% bupivacaine on each side for midline surgery. And the level of insertion, it depends on the type of surgery. So it can be either lateral, tap, subcostal, or posterior. And again, a flat trajectory and using hydrodissection to enter the plane will give you a good spread of local anesthetic. Again, these blocks, they provide only somatic pain relief. They do not provide visceral pain relief. And you need bilateral blocks for the midline. Patients may need opiates, but these blocks give them heavy opiate sparing. So if you see, as I mentioned before, that the TAP block has got the best evidence based on systematic reviews and meta-analysis. It provides marginal post-op analgesia for abdominal laparotomy or laparoscopic and cesarean delivery, but it does not provide any additional benefits when you add a spinal with opiate, a long-acting opiate like morphine, diamorphine. If you add, then the TAP blocks do not provide long enough analgesia that extends beyond the duration of spinal opiates. So adding a TAP block to somebody who's had a spinal opiate is not useful. If somebody doesn't have a spinal, either they have a GA, then a TAP block provides comparable analgesia to spinal anesthesia. This is again a study comparing epidural versus, or a systematic review comparing epidural versus TAP blocks. Continuous TAP blocks are non-inferior to epidural in terms of opiate consumption and dynamic pain scores. Most of the studies cross the midline. So there is equipoise. So there's not much of a great benefit to distinguish between an epidural or a continuous TAP block for pain relief following major abdominal surgery. So again, here, the opioid consumption at 24 and 48 hours, they all cross the midline, which means there is equipoise. You could choose either, is what the statistical studies say. The next block that we'll discuss is the quadratus lumborum block. This is one of the new and upcoming blocks. If you search for on the internet, this will be the hottest trending block. It is fraught with a lot of confusion, nomenclature, and approaches, which we'll cover in a separate topic. But I'll just cover the gist of the most useful technique, which is the transmuscular block. So the quadratus muscle is a rectangular shaped muscle. That's why it's called quadratus. And it is present in the lumbar area. It extends from the iliac crest to the tips of the transverse processes, and it is ensheathed by the lateral arcuate ligament of the diaphragm, and the anterior thoracolumbar fascia is covered by the transversalis fascia, which is in continuation under the lateral arcuate ligament with the subendothoracic fascia. So this is the reason why the quadratus lumborum blocks are proposed to have a greater abdominal wall analgesia compared to the more superficial blocks. As you could see from here, the subcostal nerve, the ilioinguinal and iliohypogastric nerves are consistently traveling over the quadratus lumborum muscle. So which means this could be offered for even hip analgesia. And if the spread happens above into the paravertebral space, then they provide even abdominal wall analgesia. So that is why this block has been used both for hip surgery as well as for abdominal wall surgery. That's the quadratus muscle. So this is a typical cross section of how you would see. This is the vertebral body. This is the transverse process. The psoas muscle is in front of the transverse process, and this is where the lumbar plexus all originates. And this is the quadratus lumborum muscle, which attaches to the tips of the transverse process. All the abdominal wall muscles, the external oblique, internal oblique, and transversus abdominis converge onto the quadratus muscle. And then you have the erector spinae muscle behind the transverse process. So all these three structures together give you the appearance of a shamrock leaf. So this is the picture that you look for when you do an ultrasound guided quadratus lumborum block. So if you were to place an ultrasound probe on the subcostal or the above the iliac crest, the picture that you're going to see is the end-on view of the transverse process. the quadratus lumborum attaching to the tip of the transverse process, the psoas in front of the vertebral body, and the erector spinae behind. And the abdominal wall muscles, they all end and converge at the level of the quadratus lumborum. So this is the ultrasound picture that you'll be getting. So over here, you could see the vertebral body with the transverse process in the end on view. The abdominal wall muscles, that's the external oblique, internal oblique, and transverse abdominis, all converging. The kidney in the front, that's the retroperitoneum. The quadratus lumborum attaching to with the tips of the transverse processes, and the psoas muscle in front. And the quadratus is enclosed by the anterior and the middle layer of the thoracolumbar fascia. And the anterior thoracolumbar fascia is covered by the transversalis fascia, which is in continuation with the endothoracic fascia in the chest. That's the quadratus and the psoas muscle that you would need to identify. So there are a lot of confusing terminologies about QL1, QL2, QL3, but in relationship to the quadratus muscle, they're called the lateral, posterior, or transmuscular when you go through the muscle of the or anterior quadratus lumborum block. So it's three relations. It's lateral, posterior, or anterior quadratus block. So over here, if you could see, if the block is performed at the lateral edge of the quadratus, it becomes a lateral quadratus block. Posterior between the quadratus and the erector spinae, then it's the posterior QL block where you're above the middle thoracolumbar fascia. Or an anterior QL block where you go through the quadratus lumborum and deposit the local between the quadratus and the psoas muscle. So these are the three block descriptions, but in our other talk, we'll cover more about the other variations. So the indications currently, which I've got the best evidence, are for cesarean sections and for hip surgery and for renal surgery. These are the three indications where they have the best evidence. And all other areas, there is just case series presentation. But it's one of the most upcoming blocks to provide extensive abdominal wall analgesia, including visceral analgesia as well, because they cover the sympathetic chain in the paravertebral space. A word of caution, the lumbar plexus can get anesthetized, so the patient may have a motor block in the leg. These are technically deep and challenging blocks, and the evidence is emerging, and every day there's a new paper which comes up about the QL block. So the technique to do it, this is only the transmuscular or the anterior QL block that I'm talking about. With the patient in the lateral position, a pillow is placed under the dependent hip so as to open up the subcostal space. A curvilinear probe is used because these are deep blocks. A longer needle is used, an 80 or 100 millimeter needle is used, and I do a posterior to anterior approach. A volume of around 20 to 30 ml is necessary on each side, and I use an anterior to posterior approach. And you could see from this scanning video that the needle approaches, penetrates the quadratus lumborum muscle and goes into the fascial plane between the quadratus and the psoas muscle. So you inject it just under the thoracolumbar fascia. So these are deep and challenging blocks. So the next block that we would talk about, which is again a new and an experimental block for abdominal wall analgesia, is the erector spinae block. The erector spinae are paired paraspinal muscles that run from the level of the neck to the sacrum. It is a multi-pennate muscle, which is composed of around 3 or 4 muscle complexes. The erector spinae is composed of iliocostalis, longissimus, and then the spinalis muscles. So, and the quadratus is just lateral attached to the tips of the transverse processes. So this block has the potential for being used for both thoracic and for abdominal wall analgesia. So again, the evidence is emerging, but this has only been restricted to the enthusiasts. So as we discussed before, the erector spinae is a muscle complex which lies superficial to the transverse processes, and an injection of local anesthetic under the erector spinae muscle above the transverse processes spreads the local anesthetic into the paravertebral space, effectively covering the sympathetic chain, giving visceral analgesia, as well as covering the intercostal and paravertebral nerves. Originally, Forero et al. Described it as a block in the outpatient setting for a patient who had chronic chest wall pain secondary to post-herpetic neuralgia and for rib metastatic deposits. So where they injected under the erector spinae muscle and they found extensive thoracic wall analgesia all along this distribution. So the way they did it was with the patient in a sitting position, hitting the transverse process, identifying the three muscles at the level of T5, which is the trapezius, the rhomboids, and the erector spinae muscle, and injecting local anesthetic under the erector spinae muscle on top of the transverse process. So the indications currently are predominantly for chest wall, but abdominal wall, there are two case series which have been reported by Ki Jin Chin and Adhikari for abdominal wall surgery, which involves ventral hernia repair, where it provides extensive somatic and visceral analgesia. So how do you do it? You do it with the patient in the sitting position. You could do it in the lateral position as well. You use a linear probe, and I tend to teach a chordate to cephalad technique, but the original description is a cephalad to chordate technique with the needle in an in-plane approach. Once the contact with the transverse process of the vertebra is established, then the local anesthetic is injected under the erector spinae muscle. So typically for abdominal wall analgesia, you need to perform it at the level of T7, which is at the inferior angle of the scapula. A volume of 20 ml of local anesthetic on each side provides spread from T6 to L2. So this is a performance of an erector spinae block. So you could see the three muscles, which is the trapezius, the rhomboids, and the erector spinae. And you could see the transverse process down here, the needle coming from a cephalad to a chordate approach. And once the contact with the transverse process is established, then the local anesthetic is injected under the erector spinae muscle. So there are a lot of case series and case reports of it being used, catheters being inserted in the erector spinae plane. And you could see that from this radiological spread of the erector spinae spreading into the paravertebral space and one into the intercostal space, and it being used for operations such as ventral hernia repair. So if you were to perform a block for erector spinae block for abdominal surgery, you got to perform it at the level of T7, a volume of 20 ml. It provides a spread from T6 to up to L2 probably, and dexamethasone and other additives have been added to prolong the duration of analgesia. 20 to 25 ml will provide T6 to L2. And this is the sensory distribution that was obtained by performance of a block at the level of T7 for a patient having a ventral hernia repair. So the choice of block depends on the expertise. The most simple blocks to learn are the TAP blocks, rector sheath, and erector spinae blocks. These could be classed as level 1 blocks. Once you're confident with your technique, then you can progress to the more deeper blocks, which is the quadratus blocks. And the transmuscular is the most difficult, along with the paravertebral blocks, to be taught in clinical practice. Thank you. That ends my presentation.